Okay, so we're talking about the paper by Ronald Britton, Hypersubjectivity and Hyperobjectivity in Narcissistic Disorders. And he starts by talking about how to work properly, certainly analysis involves trying to have an interaction between the subjective and the objective. In other words, we are seeking self-knowledge, and self-knowledge requires the capacity to be somewhat objective towards oneself. But he points out that analysts learned very early on that not all people are able to be objective towards themselves. And those are the narcissistic disorders, where people have a real severe difficulty in achieving any kind of objectivity towards themselves. At this point, I fall back on my sociological training. The American philosopher George Herbert Mead, G.H. Mead, had a huge influence on American sociology and social psychology, and I was trained in that school. Mead was very influenced by Hegel, but Mead thought that what holds society together, even a society of two people or a society of millions of people, what holds it together is the human capacity for role-taking, which is an imaginative act, and it comes with symbolic functioning. And it's the ability to imagine yourself in the other person's shoes, which is empathy. Okay, the human being is able to engage in this imaginative act. It's a pretending. It's like I'm pretending I'm you. And I'm imagining how you must be feeling. Okay, that's simple role-taking. Then, once we're able to get out of ourselves into imagining the other's experience, we are able to take a second step that Mead called reflexive role-taking, which is I'm now imagining what you're experiencing, and secondly, I'm imagining how you're experiencing me. Okay? I've gotten into your subjectivity, and now, from your subjective point of view, I'm imagining how I look to you, or what you think of me. And here I anchor my social self, which is the self that you reflect to me, or that I imagine you're thinking I am. And so Britton is talking about something very similar here, but coming out of the psychoanalytic tradition, he adds something that the sociologist never adds, which is unconscious processing. Okay, so for that whole process of role-taking and reflexive role-taking for the sociologist is a conscious, or at best a pre-conscious process. But Britton is bringing psychoanalysis to bear, and he's saying that there is this whole category of people, and he's drawing on an early paper by Carl Abraham, and he's drawing on the work of the Kleinian that we read last week, and I'm blocking on his name. Herbert Rosenfeld. He's drawing on Abraham and Rosenfeld more than anything else, and he's talking about narcissistic patients who can't do this. They cannot stand being. They can't link subject and object that way. Yeah, it's interesting. Mead says in discovering the subjectivity of the other through role-taking, I discover the objectivity of myself. I discover the ability to be objective towards myself, because I can see myself as an object from the other person's point of view. But severely narcissistic people can't do this. So here's the child, and here's the mother, and here's the father. And so the child has a relationship with the mother, and the mother with the child. And the child has a relationship with the father, and the father with the child. And mother and father have a relationship with each other. And so in his relationship with his mother, the child's subjectivity is preserved. That's his experience of his connection with his mother. And here he's a subject relating to father. But in order for him to acquire the ability to be objective towards himself, he has to take this in. And of course, that's a relationship between mother and father which excludes him. And so that's a primal scene. He's drawing heavily on Bion here. To register that mother and father have something going on together quite apart from either of their relationship with me. That's the parental bedroom. That's the fact that they have a thing between them that excludes me. And narcissistic patients can't bear this. And therefore they can't think properly. Because of course, thinking is, back to George Herbert Mead, it's having a dialogue with myself. I think something, I feel something, and then I step outside myself and I look at myself from the outside, but is that really what you feel, Dawn? Or maybe you're feeling something else. Well, I think I'm feeling, but maybe, okay, so I'm having a dialogue with myself. You know, like when you're writing, you write, and then you look at what you wrote and you edit. You bring self-criticism to bear. But that to be able to do that requires being able to grasp the idea of being observed from an outside point of view. If he registers that mother and father have a relationship quite separate from their relationships with him, he establishes the idea of an external point of view. And now he can begin to look at himself from this external point of view. And therefore he can allow the analyst to have an external point of view. And he can hear the analyst when the analyst speaks from an external point of view. Now, if patients cannot absorb the primal scene, they're too horrified, they're too persecuted to allow this, they can't think, because Bion says thinking is mental intercourse. I'm having intercourse with myself when I'm thinking. How does he put it? You have a preconception that meets a realization, and out of the connection between the preconception and the realization comes a conception, as in physical birth conception. The baby is conceived. I conceive an idea the way a couple, through their coupling, conceive a child. It's a third thing, and baby makes three. Okay? This is the tertiary position. Triangularity. But people who can't accept the triangle, they're too persecuted to know that they have a relationship with mother, and she has this thing with father, and father has this thing with mother. It's unbearable. Now, I think it's unbearable basically to everyone. I think it's the primal trauma. Forget about there's other kinds of trauma. The mother's inability to contain, the father's whatever, authoritarianism or his abuse or whatever. These are all traumas, of course. And not everyone has all of the traumas, but every human being has this trauma of having to encounter the third, and having to encounter the fact that mother and father get things going together that exclude me. If I can't bear that, and believe me, it's not pleasant for anyone. I mean, we're all horrified by it. All literature is about it. Most movies are about it. It's what makes the world go around, the instability of the triangle, right? But unless you can come to at least bear it to some degree, you can't think. And you certainly can't allow an analyst to analyze you. Because you can't tolerate that third space that the analyst goes into. And not in this paper, but in the other paper by Britton, he talks about a severely narcissistic patient, thin-skinned, borderline, who he quickly learned he couldn't make any interpretations to her. he couldn't say anything other than empathizing. These thin-skinned patients make you be a self-psychologist. It's the only thing. They force you into it. People who are ideologically committed to self-psychology, in my view, have surrendered. They've given up on analysis, and they are submitting to their patient's demand that they not analyze, that all they do is emotionally attune. Now, of course, I'm not saying emotional attunement is wrong. We all have to emotionally attune to build a working alliance and to understand our patients. But if all you can do is emotionally attune, there's no analysis that's going on, you know. You may have to do that for a long time, and then you can begin to analyze. But so this patient insisted that he not analyze. So what he did was he said to himself, actually Dr. Spotnitz recommends this, silent interpretation. If I can't make interpretations of the patient, well, okay, I'll just attune emotionally, but in my own mind, I will make the interpretations in my own mind. This patient said to him, stop that fucking thinking. She wouldn't let him think. And notice that she said fucking thinking, because Bion essentially is saying thinking is fucking. It's intercourse. And she couldn't stand him having intercourse with his theories in his own quiet mind. She couldn't stand him having intercourse with his colleagues that he would be discussing the case with in his mind while he simply attuned to her. She stopped that fucking thinking, she says. Okay? So this is de-skilling the analyst. These patients do de-skill us, the severe ones, you know. So that's what Bion's talking about here. Patients who can't bear the third. Now, he proceeds now to come back to Herbert Rosenfeld, and he says there's two kinds of these patients, the thin-skinned and the thick-skinned. The thin-skinned insist always on their subjectivity. They hang on to their subjectivity. That is, all you can do is stay with their subjective experience. And of course, this close attunement to the patient's subjective experience is celebrated by self-psychologists as wonderful technique. The better you can do it, the more closely attuned to it, the finer, subtle shades of staying with the patient's subjective experience, conscious and preconscious, basically. That is celebrated as good technique by many self and relational analysts. So they're conforming to these patients who insist that all there will be is their experience. And they don't even want you thinking about their experience, let alone giving them any kind of objective observations about how that looks to you. Shut up. So he tells the example of the little girl who could only tolerate being in the room with the analyst if she blindfolded and gagged him, because then she could be sure that she would never suffer from his gaze or from anything he said about her. And that's what it feels like with certain very borderline patients. It's like they're blinding and gagging you. All you can do is attune to their subjectivity.
And is that similar with thin-skinned narcissists?
That is the thin-skinned.
Okay, so they're borderline as well?
Borderline, thin-skinned is borderline.
Right, oh, right.
Thick-skinned is schizoid. And they occupy the third position. They can only be objective, and they cannot tolerate their own experience. Emotional experience they can't tolerate.
Technically, borderline people, they have a very severe narcissistic thing in them, right?
Oh, absolutely. These are two types of narcissistic patients.
Exactly. They're technically narcissistic.
Oh, yes. This is narcissism. This is what we're talking about. And we're talking about these two different forms of it.
Mm-hmm.
The borderline or thin-skinned, the schizoid or thick-skinned. Now, this kind of patient comes into analysis, and all he wants to do is theorize. And he doesn't want to feel anything. And he's often an intellectual, and he will theorize till the cows come home. Because he's so narcissistic, if the analyst joins in the theorizing, and say the analyst says something really smart, this patient will pick up what the analyst said, but he will change it a little bit because it's not quite good enough, you see. It's a little off. It has to be fine-tuned by the patient, i.e. the patient has to make it his own. And then he may take it up into his self-analysis, because essentially he's doing a highly theoretical self-analysis in the presence of the analyst. But what's the analyst feeling? The analyst is feeling like he's absent. He's feeling non-recognized. He's feeling useless. He's feeling devalued. He's feeling excluded. He's feeling bored. He's feeling sleepy, because the patient is conducting the analysis. And there's no affect. It's an affectless analysis, because the disaster for the thin-skinned patient is falling into a terrible state. If the analyst starts making objective observations, the borderline patient it's a catastrophe. They're terrified of falling into some catastrophic state. If the analyst says something from the analyst's objective point of view, the patient will feel persecuted, will feel attacked, as if the analyst is an authoritarian fascist imposing his theory on the patient, a kind of psychological rape. They will experience it as a kind of psychological violence, authoritarian domination, and it's very, very painful, and they dread it, just like that little girl made him wear a blindfold and a gag. All right? They dread it. The thick-skinned patient dreads something different. He dreads feeling something. And he's afraid that if he starts to actually feel something, he'll be overwhelmed. He may start weeping and never be able to stop. He may dread that he's going to get so depressed, he won't be able to function. He's busy making meaning with his intellect. He dreads that he'll fall into a state of utter meaninglessness where he won't be able to make any meaning and everything will be chaos. If he's an existentialist, he might talk about the experience of nothingness or existential meaninglessness, which he's warded off. So he's busy making meaning in an affectless way. He's afraid of his feelings, Okay, two different forms. They're both warding off what feels to them to be a disaster, a catastrophe. But they do it in these very, very different ways.
So sorry, the interplay of the borderline with the narcissist.
Well, the borderline is a narcissist.
Right, so the narcissist falls within the borderline
No,
category.
both of these are narcissists. Narcissism can take two forms: hypersubjectivity, hyperobjectivity. These are two different faces of the narcissist.
Sorry, but my question is that they're not neurotic or psychotic.
Oh,
they're borderline.
They're I see what you mean in terms of their structure. Yeah. They're narcissistic. I mean, he starts the paper by reporting what Abraham had said, and Rosenfeld, that there is a category of patients who are not apparently psychotic and are not too outwardly destructive, but they're kind of unanalyzable or very, well, no, he doesn't say they're unanalyzable. He says that they're very difficult. They're difficult patients. I mean, Britton says he's experienced analysts come to him for supervision, and they always say, I'm going to bring you my most difficult patient. He says as soon as he hears that someone's bringing him a difficult patient, he knows he's dealing either with this or with that. Yeah. Thick-skinned or thin-skinned. These are the difficult patients. No, they're not psychotic. They're not neurotic. Call them borderline. He prefers to just call them narcissists, thick or thin-skinned. He calls the thin-skinned. He uses the word borderline for the thin-skinned. He uses the word schizoid for the thick-skinned. But, same kind of deal. Right. They can't bring subjective and objective together. They can't have a dialogue. You know, and what does a good analysis look like with a neurotic patient who actually can accept the primal scene, as painful as it is for all of us? They can tolerate it enough to allow there to be a third area of interaction between subjective and objective. And what's it look like? I mean, you have your experience and your ideas, and then, you know, your analyst says, well, I have a thought about that. Or you bring him a dream and you talk about the dream, and then the analyst will says, well, but I wonder, what about that car crash in the dream? I mean, I wonder, and you're able to tolerate him thinking about you. And thinking about your experience, you're allowing him to toss some ideas in. It doesn't mean you have to obey. These kinds of patients, if the analyst weighs in with anything, these patients feel that they must either totally comply and conform, or they will be completely dominated and attacked. So they often comply quickly as opposed to being attacked by the analyst. So they can't have the kind of back and forth interplay that we consider to be good analytic work. At least for a long time they can't. Now, Britton doesn't go into these other issues. He doesn't take on the question of how do you get one of these patients to actually become analyzable. He doesn't touch that in this paper.
And obsessional might do the same.
Well, schizoid and obsessional, often highly intellectual. A lot of obsessionals, or a lot of intellectuals are obsessional. So we're talking, that's what, intellectuals, obsessional, schizoid types. Yeah. And like Rosenfeld said, and I pointed out in the week before last, I wrote a paper on Harry Guntrip, who I think embodies this. Guntrip wasn't really analyzed by Fairbairn or Winnicott. He attended sessions, he wrote everything down after the session, he wrote books about Winnicott and Fairbairn, he surpassed them both, but people said, you know, was he ever really an analysis? I think he was a schizoid, obsessional, thick-skinned narcissist who couldn't really tolerate being analyzed by either Fairbairn or Winnicott. He could only analyze himself. That's what narcissists do. Of course, they can't allow the analyst to analyze them. They can't have any gratitude to the analyst for his input. Yeah.
The paper, he also talks about the Superego being replaced by... let me pull that up, actually.
Yeah, look up that passage.
Because it's interesting you brought it up. I wasn't quite clear.
Well, he's following Bion, and Bion believes that the essence of narcissistic pathology is a savage superego, what he calls an ego-destructive superego.
Yeah, so the author suggests that narcissistic disorders arise when there is a failure of containment in infancy and childhood.
Yes.
That gives rise to an ego-destructive superego.
That's Bion.
Leading to the evolving of a narcissistic organization.
Yes, exactly.
And the libidinal defensive organization arises when parental failure of containment is the primary factor.
Yes. Well, okay, but towards the end of this article by Britton, he goes into an area that I find a bit questionable. He's following Bion. Okay, so like the old classical Kleinian analysts often spoke as if they believed that certain babies come with a large amount of constitutional aggression and envy, inborn. Following Bion, most Kleinians have moved away from this idea of inborn envy and inborn aggression, and they see what looked like inborn envy and aggression as a result of failures of maternal containment. And so Britton is drawing on Bion there, but in a way he's backing up a little bit, because he says he's not comfortable thinking that it's entirely, because he says in some of these narcissistic disorders you find no trauma. In many of them you find trauma. and clear failures of containment. But in some of them, you just don't find much evidence of trauma. And so he's wondering towards the end of the paper whether certain babies come with something analogous to an autoimmune disorder, only a psychological autoimmune disorder, a level of uncontainment that a normal baby could take without feeling traumatized. These babies are super sensitive to trauma. They're really derailed, he says. It's as if they come already with a problem before they even meet the mother's failures. Something analogous to an autoimmune disorder. That's what he's saying. Now, I don't know what I think about that. It makes me a little nervous. But on the other hand, I suppose, what is the dominant position in psychoanalysis? I think the dominant position has been to reject the idea of the schizophrenogenic mother, the refrigerator mother, a la Bruno Bettelheim, who blamed autism and schizophrenia on the cold mother. Most experts, I think, in psychiatry and psychoanalysis are inclined to think that it takes two to tango or not tango, and that a mother who might well be good enough with 4 of her babies is just not good enough with baby number 5, and that's because baby number 5 brings something to the interaction.
It's a bit relational that way.
Well, it's relational, and the idea is that there's something maybe constitutional or temperamental or inborn or something in the baby that maybe overreacts or is excessively sensitive to small failures of containment that another baby could absorb and accommodate and transcend, you know? So that's what he gets into at the end of the paper. He does follow beyond. He does see the ego-destructive superego, and it's interesting that Harry Guntrip, who I think embodies the thick-skinned narcissist in treatment, at the end of his life, he analyzes himself and he traces it back to the day he comes into the home and there's his mother with his dead younger brother's body, Percy, on her lap. And he blames her coldness for failing to keep Percy alive. And he feels that the symptom that both Fairbairn and Winnicott failed to resolve in his work with them was what he called his exhaustion illness. He had these very close male friends that are co-workers. Like he was, for many years, before becoming an analyst, he was a minister, a church minister, and he always had an assistant minister. And if that minister left for another parish or whatever, Harry would regress and have one of his exhaustion illnesses, and he'd have to take several months and go home and be taken care of by his mother until he recovered. And he didn't get anywhere with this symptom in either analysis. But after Fairbairn and Winnicott had both disappeared and died, Harry analyzed the problem himself. He traced it back to the day he came in and saw his brother dead in his mother's lap. He blamed his mother's coldness, and he blamed her coldness on the exhaustion illness. The exhaustion illness was mother's coldness. So here's this guy, he's working, you know, he's like 80 or something. He's worked for decades in psychoanalysis, and at the end of his life, the best that he can come up with is it's all mother's fault. And he's a big hero in relational psychoanalysis. It never occurred to him that the exhaustion illness having to do with his brother's death had to do with the fantasy that he killed his brother. Because all little boys want to kill their brothers. And here's his brother dead. Who does he blame? Mother, not him. And the truth is, he was incredibly competitive. He was an aggressive, competitive character. He was competing with Fairbairn. He was competing with Winnicott. But it never occurred to him that he his exhaustion illness represented his need to be dead, like the brother he killed, in his fantasy. But he doesn't get to that. See, he hated Melanie Klein. He liked Fairbairn and Winnicott, but he had no use for Klein, because Klein draws attention to aggression. He was troubled by poor old Fairbairn, because unlike Winnicott, Fairbairn kept trying to talk to Harry about his aggression, which really annoyed Harry. And Guntrip, in his own, Guntrip wrote a bunch of very good, I'm not trying to diss him across the board here. He wrote some very useful papers on schizoid conditions. And he describes the schizoid personality. His descriptions, his phenomenological descriptions are really good. But where he really misses the boat is that he doesn't see the role of the superego in any of this. And in my view, narcissists are terrified of a primitive superego. They can't take delivery of any guilt. They're, the last thing they want is to take moral responsibility. They build their personalities in such a way as to avoid any sense of guilt and regret and any sense of responsibility. And Guntrip doesn't get that, and neither does self-psychology. Because look, in his early work, Kohut said, Freudian psychoanalysis applied to the era of what he called guilty man. And he says the era of guilty man has passed around 1950. Of course, many people observed this change that happened around 1950.
Which is that we are born guilty, the Oedipal guilt? Is that
not that we're born guilty, but okay, Erik Erikson put it this way. He said, prior to 1950, patients understood who they were and who they ought to be, but came to analysis because they couldn't be it. In other words, an example might be, I'm a middle-aged husband and father, and I ought to be faithful to my wife, but I can't be. And I'm in analysis. Okay? So they knew who they were and who they ought to be, but they couldn't be it. After 1950, the patient comes and he doesn't know who he is or who he ought to be. Okay? So in Kohut's language, this is the disappearance of guilty man and his replacement by what Kohut called tragic man. Tragic in the sense that he just doesn't know who he is and doesn't know who he ought to be. He's got a self-disorder, in other words.
More existential.
Sorry?
More existential.
Yes, it is existential. Meaninglessness. Yeah. And so these self-disorders, they don't have guilt. But that's simply incorrect. Self-disorders have deeply buried guilt. They're not conscious of their guilt. If the analysis works and they progress in analysis, they will encounter their guilt. They have a savage superego. They have it all walled off. Unless that superego awakens and starts getting dealt with in the analysis. So guilt is buried in the self-disorders.
Mm-hmm.
But the Kohutians are not ever going to get to it.
Buried as an almost inaccessible, unless a
Almost
lot of work,
inaccessible.
unless a lot of work is done.
A lot of work has to be done to bring it to the fore because they've got a whole bunch of defenses against it.
Hmm.
I mean, and if the analyst sort of goes to that too soon, they're going to just be gone.
Hmm. And then this whole elevated sort of self-esteem.
Oh, this is a manic defense against feeling like a piece of shit. And their superego is telling them. You see, the sense of worthlessness, the error that the self-psychologists make is they see that the patient feels worthless, and they think it's because his parents told him he was worthless. He's a victim of parents who made him feel worthless. And that may be true up to a point, but what they're missing is that when you have parents that tell you you're worthless, a number of things happen. First of all, you internalize them and you tell yourself you're worthless. You comply with what the parents are saying. But second, being told that you're worthless by the parents makes you want to kill the parents. It makes you angry to be told you're worthless and treated as if you're worthless. So you want to kill somebody, but you can't. So you stifle the wish to kill, and you turn it on yourself. And now you are a fragmentation. Now you are a fragmented self. How did the self get fragmented? The self psychologist never occurs to them that maybe the self is fragmented because a fragmenting attack has taken place on the self. The person is fragmenting himself with the aggression that he was unable to unleash towards the parents or even think about. He stifles his aggression. He turns it on himself. He fragments himself. You know, they see the fragmentation. It's like a bomb has gone off. But they don't. They kind of see the result, but they don't think there was a bomb. They don't think that there was aggression that caused this disaster.
So all the blames are on the parents.
Oh yes, like Harry Guntrip. It's all mother's fault, and they don't understand how they're doing it to themselves. That's the task of the analysis, to lead them to that point where they can begin to see that there's something very destructive inside themselves. And that's the superego. That's what Bion calls the ego-destructive superego. So Bion gets it. Ron Britton gets it. Herbert Rosenfeld gets it. I think even a lot of the Freudians don't fully get this. I think the people who get it most are people like Bion, Rosenfeld, and Britton.
John, has ever been a treatment of a severe narcissistic patient?
Have what?
Has ever been treatment of severely narcissistic patient?
Have I ever treated it?
No. So was ever successful in the history?
Oh,
of
successful.
Even like conducted by self-psychologists or a Kleinian, you know.
Well,
how far you can go with this, you know,
now
with
by
severe narcissistic
okay,
patient,
but how severe are you talking about?
like personality disorder.
Are you okay? Are you talking about like a thin-skinned, a borderline?
Yeah.
Well, Kernberg claims, and his followers, like Frank Yeomans, he has a whole group. Kernberg had a whole group around him at the Cornell Westchester. They had a whole unit. And there were about 8 colleagues, all devoted to the study of, and the clinical technique of working with borderlines. He took them off the couch, put them in a chair 3 times a week. And he called it transference-focused psychotherapy. But it's psychoanalytic. It's just 3 times a week in the chair instead of the couch. And he claimed, he distinguishes 3 levels of borderline: lower, middle, and higher level borderlines. Higher level borderlines look like they're neurotics. That's how they get into your practice. They come, they look together, they look very civilized and everything else. It's not until you've agreed to treat them, and it's a few days into the treatment, that they start to unravel. It's like that movie Fatal Attraction. Glenn Close looked like a really together woman, and Michael Douglas proposes. His wife and kids are away. He proposes to have a sophisticated affair for the weekend, and she's a very sophisticated, calm business, very together. And at the end of the weekend, he's getting dressed and putting on a tie to go home to meet his wife and kids, and he looks back and the bed is filling up with blood. She's oops, wrong girl. That's kind of how you feel when you've taken into your practice someone who looked like they were all together, and then suddenly you see, oh my God. But anyway, back to Kernberg. He claims that higher level borderlines, even some middle level borderlines, can be successfully treated by a modified psychoanalytic method. Now, he hasn't presented the extensive case studies to prove it. How can you prove it? But I mean, I think they're a good group of colleagues. I don't think they're conducting a hoax. I think they're ethical. So I think when they claim that method has worked with a number of patients, I'm inclined to believe them. I think that to work with a thin-skinned narcissist, you have to be a very skilled therapist. You know, you first of all, you have to know about aggression. You have to know about the ego-destructive superego. You have to be able to maintain empathy. I'm saying that to work the way Kernberg does, you've got to, first of all, you have to be an active therapist. Forget about that passive sitting back and just being a listener like you're taught. You should. No. You have to have enough experience and confidence, and you have to know your theory and be diagnostically sophisticated enough to realize that you have to weigh in with these patients. You sometimes have to weigh in if you're going to get anywhere. You can't just sit back and be, because if you sit back, you'll do self-psychology for 15 years and the patient won't change. So no, you have to find ways of talking, not cruel, not harsh. I don't like that word confrontation, but what Freud meant about it is drawing the patient's attention to something. I mean, that's what a confrontation is. Did you notice that every time I mention this, you immediately change the subject? Have you noticed that? That's a confrontation. I don't know whether she'll remember it. See, that's going to be my next session. I'm asking, what did she remember anything from today? Or has she evacuated it? Is it gone? Or can she hold it in her mind?
So can you elaborate on that? If she can hold in her mind, that means she has a capacity to
learn
from
experience. Look, one of Bion's books is called Learning from Experience. And the way we learn from experience is by making links. See, that's a link, that's a link, that's 3 links. The trouble is that the narcissistic patient cannot accept that 3rd link between mother and father that excludes them. But the question is, can she link next week? Can she link what we talked about today? Can she even remember what we talked about today? Will she bring it up? Will she say last week was really interesting? I kept thinking, she might say afterwards. She might repeat what I said to her and say she'd thought about it. Or at some point in the session, she may refer to it, indicating that she remembers. Or will it be gone?
So, there are some of these narcissists are very high functioning, and they can intellectually make a lot of links.
Especially
like
the thick-skinned.
Right, like you said, the intellectually.
Is it?
Where's the failure in making?
Well,
links?
for the thick-skinned narcissist, he can link ideas. He just can't link anything with emotions. He can't experience emotions.
And for the thin skin?
For the thin-skinned, they can't link anything that's objective. They can go on talking about their emotional pain forever, but they can't accept any objective thoughts or any meaningful theory about their emotions. I mean, they'll tell you how they suffer exquisitely, but they could never accept the idea that maybe they arrange to suffer in certain subtle ways. Or they can't accept the idea that maybe they seek to suffer. Maybe they choose relationships with people who will make them suffer. Maybe they make other people suffer in similar ways as they suffer. They can't accept any of that, because that's looking at them from an outside point of view as an object of a certain sort, who does certain things and repeats certain things, right? No, they want to stick with their emotional pain and their suffering, and they want you to empathize with their suffering, but they don't want any theories from you as to how they fall into that suffering repetitively because of something that happened 30 years ago with their father. They're not interested in that. It's not that they're just not interested. They can't stand you having enough of an independent mind. Your mind is supposed to be the same as their mind. You can't have a mind of your own. That's the title of that book by Robert Caper, A Mind of Your Own. These narcissistic patients can't stand the analyst having a mind of his own. And that applies to both the thin and the thick-skinned. Like the thick-skinned, he doesn't want you to have a mind of... I mean, if you come up with an idea, he immediately incorporates it and changes it and makes it his own. There's no such thing as mutuality or dialogue, really, because that implies recognition of another mind, of otherness, of the tertiary position. So I think fairly severely narcissistic people can be analyzed, but they can't be analyzed by just anyone. They got to be analyzed by someone very experienced, who is very strong, but also kind. You have to be empathic. They do suffer. You have to let them know that you understand their suffering. You can't be blaming or reproaching. You can't be moralistic. You have to be accepting and warm, but tough. See, that's the combination that you need. Kind, but tough. So, to my mind, this is put beautifully by the best therapist of all time, Jesus Christ. He said, "Be as wise as a serpent and as gentle as a dove." That was his advice to human beings. Be as wise as serpents, but gentle as doves. See? That is good analytic technique. Wise as a serpent. The patient's not fooling you. You see what's going on. You see what they're doing, what they're up to, and how they're screwing themselves up and screwing other people up. You see all that, but you're gentle. But you're not so gentle you can't protect yourself against the serpent. And you need to deliver hard truths sometimes, but you should deliver the hard truth gently. Don't, just because you're telling the truth, don't use that as a rationalization for smashing them in the face with the truth. That's a sadistic countertransference and acting out. But you have to be strong and be able to hold firm. And you have to be able to resist their efforts to guilt-induce you.